Now coming towards the next topic, that is ventricular septal defect. Okay. So for this, we are having a scenario that there is a 6 years old child comes to OPD for the treatment of diarrhea, and he has no dehydration and vital signs are stable. On auscultation of heart, there is pansystolic murmur which has no relation to respiration or change of position. Parents are not aware of any heart problems in their son. Okay. So there is the patient who come with the complaints of diarrhea and dehydration, but on examination, on auscultation, pansystolic murmur is present and there is no change on respiration or change of the position, and the patients are unaware. So this is accidentally diagnosed. Now another scenario is that there is 1 year old male infant presented with history of failure to thrive and recurrent chest infection since birth. On examination, weight is 6 kg and he is having tachypnea and tachycardia, but no cyanosis or clubbing. Here it is mentioned that there is no cyanosis. It means that this is acyanotic heart disease. On chest examination, there is pansystolic murmur at the lower left peristernal border and loud P2. He has bilateral basal crackles and hepatomegaly as well. So in this scenario, it is mentioned that there is a history of failure to thrive and recurrent chest infection since birth. On examination, weight is 6 kg and he is having tachypnea and tachycardia, but no cyanosis or clubbing. On chest examination, there is pansystolic murmur at the lower left peristernal border and loud P2. He has bilateral basal fine crackles and hepatomegaly. So this is VSD. Okay, there are the signs of tachypnea and tachycardia and recurrent chest infections, but there are no signs of clubbing. On auscultation, pansystolic murmurs is also present. Okay, another scenario is that there is 1 year old who is toddler and brought in distress to the emergency. He has history of recurrent chest infection since birth, and the mother told that she has used to fixed early while feeding. On examination, temperature is normal, weight 7.5, respiratory rate 55, pulse 40. On inspection chest, there is Harrison sulcus and subcostal and intestinal indrawing. And on auscultation, bilateral wheeze and crackles were audible. On CVS examination, there is grade 4 by 6 systolic murmur with maximum intensity along the left lower sternal border, and the apex beak shifted laterally. Liver is also palpable. That is, hepatomegaly is also present. Okay, so remember this, that hepatomegaly is present in the VSD hepatomegaly. So this is also a sign. So in this scenario, there is features of recurrent chest infections, and okay, the temperature is normal, weight is 7.5 kg, respiratory rate 55, pulse 140. On inspection, there is Harrison sulcus. So one feature is this one, and there is subcostal and intercostal indrawing. On auscultation, there are bilateral wheeze and crackles, and on CVS examination, there is systolic murmur with maximum intensity, and apex beat is shifted laterally. Liver is also palpable. Okay, so another scenario is that there is a mother who brought her 1 year old child with complaints of net gaining weight and repeated attacks of respiratory infection. On examination, his height and weight are below third centile, and he is pink and has pansystolic murmur at the left sternal edge. Okay. So the same features are present here, that there are the repeated attacks of respiratory infections, and he has head and weight below third centile, and he is having the pansystolic murmur at the left sternal border. So what are the differential diagnoses of the VSD? And these are VSD, mitral regurgitation, and tricuspid regurg. The diagnosis is VSD, and the clinical features or routine physical examinations or auscultation is that the small VSD is usually asymptomatic and pansystolic murmur along the left sternal border is present. In moderate VSD, dyspnea, feeding difficulties, poor growth, sweating, pulmonary infection, heart failure may occur, and pansystolic murmur is loud. In large VSD, pulmonary hypertension is present, dyspnea, feeding difficulties, poor growth, sweating, pulmonary infection, heart failure, cyanosis, and pansystolic murmur is present. So these are the signs of or the clinical features for on routine physical examination for small VST, moderate VST, and large VST. The investigation options that are done is chest X-ray. In small defects, chest X-ray may be normal or show mild cardiomegaly and a slight increase in pulmonary vascularity. In large defects, there is cardiomegaly, increased pulmonary vascularity, and enlargement of the left atrium and left ventricle is seen. With pulmonary hypertension, distal pulmonary arteries become smaller, but proximal pulmonary arteries enlarge. On ECG, in small defects, ECG is normal. In large defects, biventricular hypertrophy is seen. P waves may be notched or peak. Right ventricular hypertrophy predominates when pulmonary vascular resistance is high. An extreme left axis deviation is characteristics of the VSD in endocardial cushion region as in Down syndrome. Now, the cardiac catheterization demonstrates the pressure and oxygen saturation in different chambers. The treatment options for VSD are medical management, that is, in patients with small defect, reassure the patients of benign nature of lesions and child live normal life and may heal spontaneously. In large VSD, control the congestive heart failure to prevent the development of pulmonary vascular diseases. Infants with large VSD often fail to thrive, so maintenance of normal growth is important. Congestive heart failure is treated with digoxin, diuretics, and afterload reduction medication. If patient does not respond to vigorous anticongestive measures or shows signs of progressive pulmonary hypertension, then surgery is indicated without delay. The surgical treatment is that indications are intractable heart failure, pulmonary hypertension, chronic volume overload, failure to control the congestive cardiac failure despite maximum medical treatment, failure to thrive, child within 6 to 12 months of age with rising pulmonary hypertension, child with age greater than 24 years, pulmonary blood flow more than twice of systemic blood flow, and associated with pulmonary stenosis and the development of aortic regurgitation. These are the indications that the surgical treatment should be provided for the case of the VSD. The complications of the VSD are congestive heart failure, repeated episodes of the respiratory infection, growth failure, infective endocarditis, pulmonary hypertension, and Isler-Menger syndrome, that is reversal of the shunt with cyanosis. So these are the main features, that is growth failure and repeated episodes of the respiratory infections. From this we can identify the case of the VSD. So up till now we have discussed the VSD in which the patient is having the decreased growth, pansystolic murmur which has no relation to respiration, recurrent chest infections are present, hepatomegaly is present, repeated chest infection, okay, hepatomegaly is present, weight loss, we will write it here, that is recurrent chest infections and pansystolic murmur, weight loss or decreased growth. Hepatomegaly is also present sometimes. Hepatomegaly. So these are the most prominent features to identify or diagnose the case of VSD. These are the differential diagnosis. VSD, mitral rigors and tricuspid rigors. And these are the routine physical examinations. Pansystolic murmur is present along the left sternal border in small VSD. Dyspnea, feeding difficulties, poor growth, sweating, and pulmonary infections, heart failure, and pansystolic murmur is present in the moderate VSD. And pulmonary hypertension, dyspnea, feeding difficulties, poor growth, sweating, pulmonary infection, heart failure, cyanosis, and pansystolic murmur is present in the large VSD. These are the investigation options. In small defects, chest X-ray may be normal or show mild cardiomegaly and slight increase in pulmonary vascularity. In large defects, there is cardiomegaly, increased pulmonary vascularity, and enlargement of the left atrium and left ventricle is seen. With pulmonary hypertension, distal pulmonary arteries become smaller, but proximal pulmonary arteries enlarge. In ECG, in small defects, ECG is normal. In large defects, biventricular hypertrophy is seen and P waves may be notched or peaked. Right ventricular hypertrophy predominates when pulmonary vascular resistance is high. An extreme left axis deviation is characteristic of VSD in endocardial cushion region as in Down syndrome. Cardiac catheterization is done which demonstrates the pressure and oxygen saturation, and the medical management treatment is provided. For small defect, reassure patients and benign nature of lesion, child have normal life and may heal spontaneously. In large VSD, control the congestive heart failure and to prevent the development of pulmonary vascular resistance. Infants with large VSD often fail to thrive, so maintenance of normal growth is important. Congestive heart failure is treated with digoxin, diuretics, and afterload reduction medication. If patient does not respond to vigorous anticongestive measures or shows signs of progressive pulmonary hypertension, then surgery is contraindicated without the delay. Okay. Surgery indications are intractable heart failure, pulmonary hypertension, and chronic volume overload. Failure to control the congestive cardiac failure despite the maximum medical treatment. Failure to thrive. Child with 6 to 12 months of age with rising pulmonary hypertension. Child age with greater than 2 years, pulmonary blood flow more than blood flow twice of systems. And supracrystal VSD, associated pulmonary stenosis, and the development of aortic regurgitation. These are the complications, that is congestive cardiac failure, repeated episodes of the respiratory infections, the growth failure, the infective endocarditis, the pulmonary hypertension, and the Eisenmenger syndrome. So this was all about the VSD. In the next section, we will discuss about the patent rectus arteriosus, that is PDA, and atrial septal defect, that is ASD. And then we will discuss the congestive cardiac failure and then the infective endocarditis. Thanks for watching.